Intravenous thrombolytic therapy. That's always nice to give a presentation live. And we're going to be talking about intravenous thrombolytic therapy and thromboextraction in patients with stroke or ischemic type in the anterior region of the cerebral arterial circle. What seems to be the problem? And why we are discussing it, there are two methods of proved efficiency. It's intravenous thrombolytic therapy and thromboextraction. They are equal in the degree of their evidence base, but when to use which is not always clear, and how to combine these techniques is not clear as well. And let's consider when such combination may be useful. Where can we praise ourselves and why to apply the two methods together? Formally, thrombolysis will result in the easier thromboinstruction. At least that's what general idea is. It reduces the size of the thrombi and make the extraction easier. Another advantage of thrombolysis is recanalization of distal occlusions that may develop due to embolia of new vessels, especially in the areas that are available for thrombolysis but not available for thromboextraction due to the small size of the vessels. And there is a number of parameters that should make us suspicious. Saying suspicious, I mean that applying thrombolysis, we make thrombi smaller and cause them to dissolve, but at the same time, it cannot be caught by the thrombectomy device. So it may result in a complication in this or that particular patient, and the described ectoplasmic effect that may provoke rethrombosis in case of hypercoagulation, especially when we're talking about lesions of the arterial duct, especially when it comes to MCA and similar region. How do we combine these two techniques? I have to say there is no randomization have been made so far. Thrombolysis is prescribed and is a part of the protocol for the patients in certain studies, and see that the number of cases, their number could reach 100%, and in some studies it could be performed and could not be performed. And if we analyze the way this method was applied, we could see that there are at least three ways to combine these two methods. First one is to perform intravenous thrombolytic therapy, and only when it's not effective, the perform extraction. It's certainly increase the time before thromboinstruction in such studies as AMCLEAN, Rebuscot, and there's other approaches were applied when they carried out thrombolytic therapy, and even before it's reached its maximum effect, the decision was made to perform thrombectomy. And finally, the approach that is believed to be the most adequate one that was used in studies like SWIFT Prime and others. It's when thrombolysis and thromboinstructions were performed independently from one another in presence of a certain indication. This is the design that that included both techniques and independently, and that's what recommendations today tell us to do. So when we are talking about combining these two techniques, as it was made in the randomized studies, we it's the means you haven't said anything, because there is significant difference how these studies were designed. Going back to the issues, to answer this question, let's look at the meta-analysis. The first of them says when we perform thrombolytic therapy, and it was effective, and if no IV thrombolysis was performed, it didn't improve any effect in the patient. It's quite a large meta-analysis. And if we look at another one, which is also quite big, we can see that even in presence of thrombolysis and in absence of thrombolysis, the outcomes in patients after thrombectomy extraction were better than in patients without thrombolytic extraction. So which means you can find meta-analysis in your own taste and follow its results, and which says that our knowledge and most likely the studies that have been performed are not quite reflect the reality the way it is. But luckily, we finally seen several randomized studies. One of them is a SCEP that included only Japanese patients and these patients are quite different from those in Europe. Actoplus in the dose in 6.5 milligram per kilogram. This is a dosage included in their manuals and recommendations. In Russia, for instance, these doses 0 up 9 milligrams per kilogram, and the study has shown no preference for thrombolytic extraction alone, but it's been proved that using thrombolytic extraction alone reduces the number of intracranial hemorrhages. Another similar study, DBT, covered Chinese patients. These are two randomized studies with the populations of patients quite different from ours. The dosage of thromboembolysis was 0.9 milligram per kilogram, and the plan had been to involve much more patients, but it was stopped earlier because much earlier they reached the result proving that thrombectomy alone is not better than using the two methods. It's in combination. So once again, we have two randomized studies that have similar design but get different results. For instance, in the Chinese study, the difference in hemorrhages between the two groups was none. And in order for us to talk about our patients and how we should manage them,
73 человека.
Let's talk about this study on the slide. Over 1,000 patients of 70 years of age in average. All were patients with LVO in the carotid circle, and the study was finalized in 2020. It involved a regional vascular center that keep recording the general register. So what were the results that we obtained? These are the results of the real work of the regional vascular center with no randomization whatsoever. It's the retrospective study, and what we pay attention to is that the groups who underwent combined reperfusions and thrombectomy in general are comparable. But pay your attention, in the group of the patients who received only thrombus extraction, there are more patients who underwent ischemic stroke. In this group, there is more patients who underwent double diaphragm therapy, and this difference is important because it's clear that the group of patients and thrombolysis that had more strict selection criteria due to counterindications. What other differences we have to pay our attention to? If we are talking only about intravascular thrombectomy, there were more patients with SMO exceeding 1, and there were more patients with ischemic manifestations post-operationally. And they suffered of more ischemic changes.
Аспект 9, 10, 6, 8, больше 6.
In all the group, the aspect 6, 8, and 9, there were more patients on combined treatment, and their ischemic level was lower than in patients with thrombotic instruction alone. And the New York scale of severity was also different. So the patients combined study, they initially, upon admission, had lower NIH SS score, and they remained so after 24 hours passed. And these parameters in two groups compared were similar. So the patients who underwent reperfusion with MT alone and the patients on combined treatment, there are two different groups due to the criteria of selection. If we look at the intracranial occlusions they suffered, that statistically significant differences were not found. Both the localization and the degree of the lesions were similar. And when we consider some other characteristics, we could see that the patients that were on the combined therapy arrived earlier than the patients who underwent a thrombotic extraction alone. And please pay your attention that in the group that received thrombotic extraction, that combined treatment was significantly different in terms of thrombectomy duration, which proves confirms some other studies that said that thrombolysis reduced the number of passes required to remove the thrombi. But the difference between the groups in total was not significant. So our working hypothesis was that the patients with LVOs in a carotid circle of circulation, those are patients who met certain criteria, they underwent the combined studies and their treatment, and their results were better than those who underwent only thromb extraction. So, as you can see, the initial distribution demanded the better prognosis for the group of patients on combined the study. In other words, the outcome was better not because you've performed one procedure or two, but because the selection criteria were different. The same holds true for thrombectomy alone. So the patients selected for this group had more severe conditions than those on combined treatment. And if we compare the chance difference and outcome and perform outcome comparison that involves the age and the admission criteria and other different aspects before admission, the chance difference will be more precise than in case of direct comparison. So if we count a favorable outcome just like that without any other factors taken into account, we can see the difference is to be 1.14 upon admission. But at the same time, if we perform the logistic regression analysis, this statistically significant difference disappears. So if other factors, if you assess a patient in complex, you can see the functional results to be the same with no statistically significant difference. The good reperfusion also changed. Both calculations demonstrate that in the group of combined study, the likelihood of good reperfusion is higher than for patients with thrombo extraction alone, which confirms that statement of ours that thrombolysis in makes thrombo extraction easier. The same goes for complications. No difference has been identified between the groups. And we also could see that the improvement could be achieved within the first 24 hours for patients combined treatment within the first 24 hours. But unfortunately, such intensive positive dynamics could be explained by more positive recanalization didn't finalize in improvement in the RS scale. So our study has proven there is no significant difference between combined reperfusion and thrombo extraction alone doesn't exist, at least at the level of regional vascular center. And that's where we have to ask ourselves a very important question, whether the goal of our study has been properly selected. And answering the question how it's better to treat our patient in a combined way or with thrombo extraction alone, and if we get rid of the medical component, this question could be changed and put in a way what's better, to swim or to do mountain skiing? And the answer is simple. For some people, it's better to swim. For some patients, it's better to do a mountain skiing, even with the same number of those who drowned and those who broken their neck doing mountain skiing. So for
по всей видимости, нуждаться в выполнении комбинированной перфузии или только внутрисосудистой тромбоэмболэктомии.
The whole, but also to subdivide those subgroups who would definitely need additional therapy in order to reach a positive outcome. And I'm not going to come into details talking about the reduced risk of reperfusion and improved functional outcomes. So all in all, three groups were identified. Group number one, which is better to perform a thrombectomy alone, and the second group who's better to perform thrombolysis alone, and a third group that is most interesting for us because it benefits from applying both methods, and it's the most interesting group for us. But it's not only difficult to say how to combine these two techniques, but it's also the most expensive group to treat in terms of such criteria as age. The patients over 60, they benefit from thrombectomy alone. This is most likely because they have more or less healthy vessels, and unlike elder people, and thrombolysis is beneficial for people in the age over 70, while in patients over 80, you can use any of the methods listed or their combination because they benefit in any way with certain level of complications they're gonna develop, but the level of these complications is not gonna be statistically significant. And since the severity of stroke is sometimes not very high, and this is the group where who benefit from the combined treatment. So talking about patients with ICA occlusions, that's extraction that is beneficial for them, and if it comes to BCI, ICI patients, these are the patients who benefited from the both methods performed, and no difference were found between the localizations area. It also became clear that the level of glucose is essentially important as one of the parameters that could affect for selecting the method of treatment. And, since it was an observational study, we couldn't follow the technique, and since we had no data on functional outcomes, unfortunately, we couldn't follow up these patients properly. Currently, we are building up such a system that will allow us to obtain 90-day follow-up outcomes. And in terms of technical outcomes, our regional centers are very different, so we had to average the result obtained. And if we're talking thrombolytic extraction alone, I couldn't answer this question because if you refuse to perform IV thromboembolysis in favor of thrombo extraction alone, how can we be sure we've performed
и мы получили такой же результат? Это, пожалуй, этический вопрос.
Wouldn't have improved the results, which is a very serious ethical issue that prevents us from carrying out thrombo extraction alone. And in conclusion, I'd like to say that today, in our opinion, the patients, the stroke patients, they require a differential reperfusion treatment. How it could look like, I've tried to describe to you. And the second thing I'd like to pay your attention to, that combined reperfusion, at least at the level of regional centers, doesn't provide any better outcome than thrombo extraction alone. But nevertheless, this conclusion got to be confirmed with more randomized and controlled studies.
Спасибо за внимание.
So, thank you very much for your attention.